It is common knowledge in both the US and in Canada that there are many similarities between the two countries. But although these countries share many things in common, such as education systems, democratic political structure, and the English language, there is one area of public policy that is vastly different in the two countries: healthcare. Public health has traditionally been a large political issue, but in the past decade of war and economic instability, healthcare has somewhat been on the back burner in the US. With President Obama introducing Obamacare and attempting to initiate healthcare reform, there has been some movement recently, but not sufficient for any large changes to occur. This video will explore the history and structure of both the Canadian and American healthcare systems, comparing and contrasting them in a critical analysis. Healthcare is extremely significant in both the US and Canada due to its obvious importance to survival and well-being. For you to understand the differences between the two systems, you must first understand the systems themselves. Let's dive in, beginning with the Canadian healthcare system. It was not until 1946 that the first Canadian province introduced near universal healthcare coverage. Saskatchewan had long suffered a shortage of doctors, leading to the creation of municipal doctor programs in the early 20th century, in which a town would subsidize a doctor to practice there. Soon after, groups of communities joined to open union hospitals under a similar model. There had thus been a long history of government involvement in Saskatchewan healthcare, and a significant section of it was already controlled and paid for by the government. In 1946, the Cooperative Commonwealth Federation government in Saskatchewan passed the Saskatchewan Hospitalization Act, which guaranteed free hospital care for much of the population. Premier Tommy Douglas had hoped to provide universal health care, but the province did not have the money at the time. In 1957, the majority Liberal government under Louis Saint Laurent passed the Hospital Insurance and Diagnostic Services Act to fund 50% of the cost of public health care programs for any provincial government that adopted them. The HIDS Act outlined 5 conditions: public administration, comprehensiveness, universality, portability, and accessibility. By 1961, all 10 provinces had agreed to start HIDS Act programs. In Saskatchewan, the act meant that the federal government would now pay for half of their current program. Premier Woodrow Lloyd decided to use this freed money to extend the health coverage to also include physicians. The programs in Saskatchewan and Alberta proved a success, and the federal government of Lester B. Pearson introduced the Medical Care Act in 1966 that extended the HIDS Act cost sharing to allow each province to establish a universal health care plan, an initiative that was drafted and initiated by the Liberal Party and supported by the New Democratic Party of Canada. It also set up the Medicare system. In 1984, the Canada Health Act was passed under a majority Liberal government, which prohibited user fees and extra billing by doctors. So, what does this jumble of history all really mean? Well, for starters, Canadians don't pay a cent when they go to the doctor. Ever. All hospital and doctor visits are covered by the government, which is primarily funded by income tax from Canadians. Under the terms of the Canada Health Act, all insured persons, essentially legal residents of Canada, including permanent residents, are entitled to receive insured services without co-payment. Such services are defined as medically necessary services if provided in hospital or by practitioners, usually physicians. Approximately 70% of Canadian health expenditures come from public sources, with the rest paid privately, both through private insurance and out of pocket. The extent of public financing varies considerably across services. For example, approximately 99% of physician services and 90% of hospital care are paid by publicly funded services, whereas almost all dental care is paid for privately. Most doctors are also self-employed private entities. Now that you have a better grasp of the ever-changing entity that is the Canadian healthcare system, here is a brief overview of the American healthcare system. As the demand for hospital care increased in the 1920s, a new payment innovation developed at the end of the decade that would revolutionize the market for health insurance. The precursor to Blue Cross was founded in 1929 by a group of Dallas teachers who contracted with Baylor University Hospital to provide 21 days of hospitalization for a fixed $6 payment. The Baylor plan developed as a way to ensure that people paid their bills. Prepaid hospital service plans grew over the course of the Great Depression. Prepaid hospital care was mutually advantageous to both subscribers and hospitals during the early 1930s, when consumers and hospitals suffered from falling incomes. While the prepaid plans allowed consumers to affordably pay for hospital care, they also benefited hospitals by providing them with a way to earn income during a time of falling hospital revenue. Since single hospital plans generated greater competition among hospitals, community hospitals began to organize with each other to offer hospital coverage and to reduce inter-hospital competition. These plans eventually combined under the auspices of the AHA under the name Blue Cross. After the success of Blue Cross and Blue Shield in the 1930s, continued growth in the market occurred for several reasons. The supply of health insurance increased once commercial insurance companies decided to enter the market for health coverage. Demand for health insurance increased as medical technology further advanced and as government policies encouraged the popularity of health insurance as a form of employee compensation. By the 1960s, the system of private health insurance in the United States was well established, although there were still some who pushed for a national health insurance policy. The American Medical Association was a vocal opponent of any nationalized health insurance programs, suggesting that such proposals were socialistic and would interfere with physician income and the doctor-patient relationship. Proponents of such legislation worked to ensure that their ideas would have a chance at passing in the future under a more responsive administration. They realized that the only way to enact government-sponsored health insurance would be to do so incrementally, similarly to the marijuana reform advocates lobbying for medical marijuana, and they began by focusing on the elderly. Passed in 1965, Medicare was a federal program with uniform standards that consisted of two parts. Part A represented the compulsory hospital insurance program the aged were automatically enrolled in upon reaching age 65. Part B provided supplemental medical insurance or subsidized insurance for physicians' services. Currently, the United States has approximately 80 million Americans participating in the Medicare and Medicaid programs, and the two programs together accounted for 32% of all healthcare expenditures in 2001. Finally, we can now begin to critically examine the vast differences between the two systems that have been presented. The largest and most obvious difference between the two systems is the for-profit system of the U.S. versus the not-for-profit system employed by Canada. In the U.S., health insurance companies compete to make profit and often remove services that are covered under a deductible. A large flaw presented by a system that is for-profit is the exclusion of patients from the equation. Health insurance companies in the U.S. calculate costs based on numbers and statistics, not based on actual need. Therefore, it is common for people in the United States not to purchase health insurance due to the high costs associated with it. Studies suggest that 40% of United States citizens do not have adequate health insurance, if any at all. To contrast this, in Canada, everyone is provided with health insurance as it is a right given to every Canadian citizen, regardless of his or her health and/or economic status. Because the Canadian healthcare system is not for profit, statistics and other things are not a factor in deciding whether a person should be covered. A huge issue that is often pointed out as a flaw in the United States healthcare system is the amount of money that is spent. In 2006, per capita spending for healthcare in Canada was $3,678 US. In the United States, it was $6,714. The US spent 15.3% of gross domestic product on healthcare in that year, whereas Canada spent only 10%. To even further contrast this, in 2006, 70% of healthcare spending in Canada was financed by government versus 46% in the United States. Total government spending per capita in the U.S. on healthcare was 23% higher than Canadian government spending, and the United States government expenditure on healthcare was just under 83% of total Canadian spending. Based on these numbers, one can conclude that not only is the Canadian healthcare system more inexpensive to the government, but it is also far more cost-effective. According to Chapter 4 of the PR book, bureaucracy accounts for 31% of health spending in the U.S. versus only 17% in Canada. This equates to $350 billion annually that is being wasted. There is one flaw with these numbers, though, and that is the fact that they do not take into account population. This is the biggest problem that I foresee with the U.S. attempting to reform healthcare. Although I do not believe that healthcare should be privatized and used as a means for making profit, it is somewhat difficult to imagine a system that would provide coverage for the enormous population of the United States and not significantly raise taxes. However, I do not believe that a tax increase would significantly hurt Americans more than copays and high deductibles are hurting them right now. I'm a big proponent of taxing the extremely wealthy, and thus I believe that some of the cost should be borne by the 1% as a way of giving back to the rest of the nation. A large criticism of the Canadian healthcare system that could affect a public health system in the United States is long wait times. As reported by the Health Council of Canada, a 2010 Commonwealth survey found that 42% of Canadians waited 2 hours or more in the emergency room, versus 29% in the United States. 43% waited 4 weeks or more to see a specialist versus 10% in the United States. The same survey states that 37% of Canadians say it is difficult to access care after hours, without going to the emergency department over 34% of Americans. Furthermore, 47% of Canadians and 50% of Americans who visited emergency departments over the past 2 years feel that they could have been treated at their normal place of care if they were able to get an appointment. If it is not already abundantly clear, while Americans may have a slightly faster and more technologically advanced medical system in place, its unavailability to so many makes its efficiency somewhat useless. Life expectancy in the United States is 2 years shorter than in Canada, and infant/child mortality rates are also higher in the United States. As stated in the articles in PR Chapter 4, poverty and inequality can literally be dangerous to your health. Without an employer who provides health insurance, many citizens are left to fend for themselves, as many of these middle to low income people do not qualify for Medicaid. Universal health care is not a right as it is in Canada. Another large issue that is raised by a medical system that is controlled by economic status is that of racial disparity within the system. As highlighted in PR Chapter 5, there are economic and social inequalities that occur due to race and gender. Therefore, since the healthcare system is dependent on one's economic status, the trickle-down effects of this economic inequality automatically links itself to the healthcare system. The black man or white woman who lost out on a job opportunity due to it being given to a perhaps less qualified white man will be without health insurance and income due to being unemployed. As Witt says in Chapter 14, race is a system of difference that is tied to power and the distribution of material, social, and cultural resources. The primary cultural resource being healthcare in this case. Based on the information that has been presented, it is my opinion after much thought and research that the Canadian healthcare system is more effective and even humane than that of the United States. Much like the education system, the United States healthcare system clearly demonstrates the societal harm that privatization can cause and the inequality that it promotes. The for-profit system, as mentioned previously, leaves the consumer out of the loop, providing them with minimum benefits for their money, while a business executive at an insurance company profits from them. Much like the message promoted by the Zeitgeist movement, I believe that people should protest this inequality and demand universal healthcare for all citizens of their country.